So the topic assigned to me is kind of sandwiched between the Th2 inflammation and speakers coming to talk about comorbidities and biologic therapies. So what is the allergist approach to asthma? So to the non-allergist, what is the message? So what do we do differently than the pulmonologist? We do environmental assessment, we do allergen assessment, and we address those issues very seriously. Why? As you saw in the previous talk, the role of the Th2 inflammation in asthma has never been more profound than what we find now. So I'm going to focus my talk on the evidence for environmental assessment and environmental remediation, and allergen assessment and allergen remediation. I have non-disclosures relevant to this talk. My objectives, of course, Dr. Falvio made my job very easy. He's an excellent speaker. I like him a lot, and he has put it very elaboratively. So it gives me some time to focus more on the other two. What is the evidence and role of allergen immunotherapy in asthma management, and what are the endotypes and specific biologic therapies? So in the pre-biologic era, the asthma as a model, or allergic diseases or diseases as a model, we were always looking at the adaptive immune response. So this is naive T cell polarizing to Th2, and that is causing the asthma, that is causing the allergic rhinosinusitis, that is causing the atopic derm, that is causing the food allergy. But a new player came on board, which is the interplay mechanism, where we moved away from adaptive and saying that, okay, adaptive immune system are the responders, but who are the offenders? So, I mean, it is an interplay between genetics. Of course, allergic diseases are more often hereditary, and a barrier dysfunction at any level, at respiratory epithelium level, or skin level, or a gut level. And more data is coming on the microbial manipulation as well. So the Th2 inflammation is an interplay of genetics, microbial and environmental factors, and innate immune responses occurring at the barrier level. So we moved away from, okay, adaptive is the culprit, to the adaptive is the responder, whereas the effector is the barrier or the innate immune system. So of course, this is a concept very popular among the pediatric allergists and pediatricians. I'm sorry, the food allergy graph went away. So the atopic march, if you see, it starts at the atopic diathesis, and then later the child develops asthma. So it is telling us that the Th2 inflammation is going to be as it's uncontrolled, it's going to be progressive, and it will lead to asthma in 70% of severe atopic dermatitis. Th2, I'm not going to spend a lot of time, but the understanding has changed. In the Th2 asthma, we were always thinking it is the adaptive immune system or adaptive cytokines playing role. But where is it originating? It is, as I told you, an interplay between genetics and microbial alteration and the barrier dysfunction. The barrier, three main cytokines are coming, TSLP, IL-33, and IL-25. And if you see in some scenarios, non-allergic activation of IL-33 and IL-25 is also there. And this will also activate innate-like lymphoid cell too, and that is causing the downstream cytokines, which are causing the asthmatic inflammation. The reason why this is important is our entire approach is directed on how we are going to counter these. And again, the same thing showing the Th2. And one more thing is, even in the non-allergenic, you're going to see irritants, you're going to see microbes, you're going to see pollutants, which again, in some aspects can increase the IL-25 and IL-33 and can activate the ILC2 and cause the downstream eosinophilic and cytokine response. So it is not only, so the Th2 asthma, we are moving away from purely allergic to looking at the barrier defect leading to, from other reasons as well, leading to Th2 specific cytokine production. So this is very important in the understanding. As I told you, we are moving away from adaptive towards innate in the asthma world. And again, this is another slide which Dr. Falvi has already presented. And of course, what are the end results if you have Th2 inflammation? Symptoms reduction in the lung function, poor quality of life, exacerbations, airway hyperresponsiveness, and the remodeling effect, which is going to go on and on. And this is where we come on board, okay? And if you look at the data in the asthma world, the Th2 asthma is around 50 to 70%. Please don't think Th2 asthma means it's alone coming from the allergen pathway. There is non-allergen barrier defect laden activation of the Th2 pathway as well. So we, as an allergist, we deal with the anti-Th2 pathway. And of course, if you see the pathogenesis and the remodeling effect, the reason why I put this is in the asthma world, the allergist as well as the pulmonologist in the asthma centers, when do we intervene? Do we intervene late? In the pre-omalizumab era, we were intervening very late. The omalizumab was always in the beginning, 2003 to 2006 was reserved to severe persistent. But of late, our understanding has changed, and it is that the earlier you intervene in moderate to severe persistent asthma, the better the outcomes are in terms of preventing remodeling, okay? And of course, it's never complete without, we're going to switch gears and look about the GINA way of approach, which is very common here compared to EPR4 in US, and which pretty much are same things, they are like different views of the same image, okay? So you do assess, and then you do review, you do assess, you do adjustment of the treatments. I'm not going to go more in detail because this has been well adapted, and of course the GINA guidelines, which we are all very familiar. So in the asthma, GINA and EPR3 before had an approach where you assess in the risk domain and the impairment domain, and later on, how do you control and how do you reduce the risk? So the overall asthma control, you first have to assess what is the current control, and the current control you define by what are the symptoms, and how often is the reliever used, and how is the lung function, and how is the quality of life. And in terms of reducing the future risk, you need to know how severe are the exacerbations, and how much of lung function deficiency is there, and what are the medication side effects, and how worrisome is this, how often the exacerbations leading to emergency visits or hospitalizations. And how do we assess control? We have a very standardized validated asthma control test, which we all use. So, and we look at what are the factors leading for exacerbations, viral respiratory infections, allergens, air pollution, occupational. In some patients have exercise and cold air, stress, bacterial infections. So I'm just going to, so this is a very, very important slide in terms of environmental remediation. As I told you, what do we as an allergist do different than pulmonologists? We focus on environmental remediation. So first, is there evidence that this works? So this is CDC data, okay? So sufficient evidence of causal relationship with asthma. There is established causal relationship with house dust mite, inner city asthma, cockroach, anywhere in the world, cat allergen, and sufficient evidence of association is there with dog, molds, rhinovirus, and association with domesticated birds, chlamydia and mycoplasma, pneumonia and RSV. In terms of chemical agents, is there evidence of causal relationship? Yes. Passive smoking exposure among preschool age children, there is a causal relationship, and sufficient evidence of association. Yes, high nitric oxide synthase. Sufficient evidence of association, environmental tobacco smoke, formaldehyde, and fragrances as well. So there is causal relationship established. There is association relationship established. So what is CDC recommending? In terms of reduction of house dust mites, bedding encasements, or we call it as dust mite covers. And so the reason why I'm putting this slide is for the non-allergist, what do we do differently than what pulmonologist does? And why do we do it? Why we do it? Because there is a causal relationship and there is a strong association in sensitized individual. If a patient is sensitized to house dust mites and has asthma, the treatment is not complete with dust mite remediation. So, and what is evidence? Because there is a lot of literature. If you go to Google or if you look at anywhere, there are sprays which people say you need to spray, or there are people come and do extensive treatments and charge you a lot. So what is having evidence and what is recommended? Mattress encasements, washing the bed liner weekly, and avoiding downfiling, and limit stuffed toys or stuffed animals, especially in the pediatric asthma, and their indoor humidity levels in certain times of the year to 45 to 55. So these have shown evidence that the allergen exposure reduction measures will have improvement in the asthma. Of course, tobacco smoke, as you know, passive smoking is in fact a crime because it has a causal relationship with pediatric asthma. So passive indoor smoking exposure to which susceptible child and developing asthma, there is a causal relationship. So it needs to be addressed in pediatric asthma, in adults as well, passive smoking and active smoking. And cockroach plays a very, very big role and often undermined in inner city asthma, okay? In New York, Chicago, Los Angeles, or any big metro cities you take anywhere in the world, there is a strong association between cockroach allergy and inner city asthma. So it is very important to identify allergen sensitization and to do remediation. If inner city asthma, you don't address cockroach issue, you're not going to get good asthma outcomes, okay? Oriental cockroach and brown banded cockroach. So this is called a German cockroach, and this is American cockroach. This is Dubai. So we are having all three in this region, in Middle East as well. So it is very, very important. I can never stress the importance of inner city asthma and role of cockroach allergen sensitization and importance of pest control. That plays far, far bigger implication in terms of asthma control. Exposure to pets in those who are pet sensitized, who have pets, who have allergen sensitization and asthma. One thing you remember, the cell-to-cell junction in the respiratory epithelium is 10 micron gate, okay? And the cat allergen is 6 microns. So the gate is wide open for cat to go in. So, so people who are sensitized to cat and who have cat allergic asthma, having a pet cat, you're not going to have good outcomes if you're not addressing it. So this is very, very important, okay? So people who are allergic to pets, especially those to cats, should not have them in home, or at least at the minimum, the pet should not be allowed into the bedroom 24/7. The single most intervention which will help with pet allergen induced or exacerbations of asthma is keeping the pet out of the bedroom 24/7. There is no such thing as hypoallergenic dog. Okay, we published in Annals of Allergy, Asthma, and Immunology, 3 centers together. We took patients with asthma. We looked at dog allergen sensitization, and then we looked at the hypoallergenic breeds, and we looked at those patients as well. There is no such thing as hypoallergenic dog. In the name of hypoallergenic dog, thousands of dollars or dirhams are spent, especially those who have dog allergy and asthma. There is no such thing. Okay. So it is very important to keep the pet out of the bedroom, to get it washed twice a week, to do the HEPA air purification, to do the vacuuming with the HEPA air purifier device. So the CDC recommendation is do not have the pet if you have pet allergic asthma, or at the minimum, if you're unable to do it, the pet should not be allowed into the bedroom 24/7. So mold, again, if you see there's a 80-20 rule we often see with mold allergy, anywhere in the indoor allergen sensitization and asthma, 80% dust mite sensitization and close to 20% or more mold allergic sensitization. Of course, also outdoor molds also play a role. So eliminating mold and moist conditions, okay, they play a role significantly in mold allergic asthma. So again, this is a strong CDC recommendation. So what we do differently than the pulmonologist is the environmental assessment, identification of sensitization of allergen by doing skin prick testing or RAS testing, and appropriate remediation. House dust mite, pet dander, cockroach, mold spore reduction measures, they play far more important role. So this is exposure reduction measures which have evidence which CDC is recommending. Now, what about allergen immunotherapy? So allergen immunotherapy, before I go into the slides, I want to highlight a few things. If there is one thing which can prevent progression of asthma in a child or an adult, we have mild to moderate persistent early stages. The only one thing which prevents progression of disease is allergen immunotherapy. There is no other thing which has as high evidence as allergen immunotherapy. Allergen immunotherapy in pediatric patients will prevent progression of asthma. So ARIA guidelines have very clearly highlighted John Bush case studies. In the adult as well, subsequent studies in US have demonstrated that allergen immunotherapy in mild patients or early moderate persistent asthma patients will prevent progression of asthma, but there are certain conditions which need to be taken care. Okay, So of course, what is allergen immunotherapy? We take microscopic amounts of sensitized allergen and we give it periodically to induce tolerance. Mechanism of how it works, with the allergen immunotherapy, there is as you saw, Dr. Falvi has mentioned, there is a TH0 to TH1, TH2 polarization, which is causing the allergic disease, especially the allergic asthma. Here, how can we reverse the TH2 back to TH1? With the allergen immunotherapy, what will happen is there will be increased amount of TGF beta and IL-10, so that promote the Tregs, and that will suppress the TH2, IL-4, IL-5, and IL-13. Okay, and also will decrease the co-seasonal rise in the IgSO. Other effects, of course, CD425 positive T regulatory cells will also come high, okay, and TH2 cells will be low. And there's an increase in the TH1, interferon gamma. So these are all markers which we measure in the research or lab setting. But basically what happens is there is a reversal from TH2 to TH1. There is increase in T regulation. There is suppression of TH2. So the TH2 asthma, which we saw, there is a reversal with this. Is there any other thing which can reverse TH2 asthma other than allergen immunotherapy? So dust-mite immunotherapy, there are quite high quality trials, and they found that significant decrease in asthma symptoms, significant decrease in asthma medications, decrease in mite-specific immediate and late phase reactions. So in the dust-mite allergic asthma patients with the immunotherapy, there is a significant decrease in asthma symptoms. There is decrease in asthma medications. And if you want me to go on and put the nice verbiage, there is decrease in exacerbations, there is decrease in need of oral corticosteroids, there is improvement in the quality of life, what all the recent, biologic trial data shows, you're going to find all this. This is a landmark meta-analysis. Only after this, every insurance company in US started approving allergen testing in asthma patients and approval of allergen immunotherapy. No matter how bad the insurance is, every insurance has been mandated to approve allergen testing in asthma patients to identify if they have any allergen sensitization. And why not? Because 50 to 70% is TH2 asthma, and approve the allergen immunotherapy. This is, again, a task for us in the region, to use this as an evidence, a very high quality evidence, not only in US, in Europe as well. Of course, most of them are nationalized, but non-nationalized private health insurance, even Australia, New Zealand, everywhere, allergen testing was approved and allergen immunotherapy was approved. So I guess it's time for us as well to step up in the region and then work with the insurances in terms of showing them the data, the evidence, and trying to get approval for allergen testing and allergen immunotherapy across the spectrum for asthma patients. And these are a number of trials which show you that the immunotherapy for dust mites and also some other allergens are listed here is quite effective in terms of prevention of progression of asthma, especially mild asthma patients, as well as moderate persistent asthma, well-controlled, very early stages. So again, this is a 5-year follow-up study. Okay, does it really prevent asthma? Okay, if you look at the immunotherapy group, and if you look at the control group, immunotherapy group, 30% 5 years later did not develop asthma. If you look at the control group, around 22 of them developed asthma. So this is very, very clearly showing that there is role for allergen testing and allergen immunotherapy in the asthma, because we know that now that a lot of the times 50 to 70% you're seeing TH2 asthma, and the predominant players in TH2 asthma are allergens. And if you don't do allergen testing and if you don't do allergen immunotherapy in the right patient, how would we improve the outcomes? So this is what we as allergists do in asthma. So preventive therapy in children, odds ratio of developing asthma in those without immunotherapy at 5 years, okay, compared to those with, this is a slit study from Europe, okay. And if you see that, the control group and the asthma group, the slit, had higher prevention, whereas the non-slit group had lower prevention, So 5 years down the line in the adults as well as in the pediatric, you're seeing with allergen immunotherapy, you're preventing asthma. And CAT immunotherapy trial, it's a double-blind placebo-controlled, decrease in specific and non-specific bronchial sensitivity, decreased skin prick, decreased eye nasal asthma symptoms with CAT allergen, and improved asthma control. Okay, So this is what they found. One more thing I want to mention, cat is cat allergen immunotherapy doesn't work when there is a pet cat at home. So that is the fundamental important aspect to remember. A lot of the times I see in the community, sometimes cat allergen immunotherapy is prescribed and the patient is having a pet cat, so it won't work. Immunotherapy for pollens, indicated for management of pollen allergens, decrease in co-seasonal rise in IgE-specific pollen with long-term immunotherapy has been noticed. So will immunotherapy prevent sensitization of newer allergens? Yes, of course. Obviously, if you see the immunotherapy and control group, immunotherapy patients, the newer allergen sensitization rate is much less compared to the control group. Improvement of medication requirements and symptom scores after immunotherapy, okay? The dust mite and others, the molds, the dander and pollen, significant symptom improvement, significant reduction in the medication, and decreased bronchial hyperresponsiveness. Even bronchial hyperresponsive challenges were also done. Even they are also significantly less. So very high quality evidence from Quad AI, and this is suggesting that immunotherapy plays a big role. So it is for us in the region to step up and make sure that allergen testing is done when we are suspecting Th2 asthma, and appropriate immunotherapy is done in the right patient. Of course, some conditions apply. Immunotherapy alone, I can talk for 1 hour. One is FEV1 has to be above 70. Patient has to be mild to moderate, well controlled, and should not be on beta blockers, should not have any pre-existing cardiac conditions. So there are some things, should not have any high tryptase levels. So these things need to be taken care. So we moved into especially the immunological management of asthma, we moved into the biomarker era, right? So the heterogeneous, asthma is a very heterogeneous disease. You have, you have so many phenotypes, and then now we have biomarkers to help us identify the endotypes. And in the Th2, you saw that we have high Th2, low Th2, and mixed. And again, there are biomarkers which are going to help us, identify the Th2 and non-Th2. Predominantly, we look at IgE, we look at eosinophil, because sputum eosinophil is not realistic. We look at peripheral eosinophil count. We look at exhaled nitric oxide as a marker of eosinophil activation. Periostin level can be done in some settings. So these will all help us to do the endotyping. And then this is a slide on I'm not going to go much into this because the speakers coming, are going to talk about specific biologic therapies. I'm sure they'll address. But as you saw, the ILC2, the TSLP, the IL-25, IL-33, Th2, and downstream Th2 cytokines playing role. And this is how we are going to do it. And this is a landmark study from Severe Asthma Research Program, which has found that around 55% of the patients have eosinophilic asthma and 6 mixed granular, okay? Telling you that the role of Th2 inflammation is quite high. As I mentioned, 55 to 70%. I think, again, this has been presented, various things which can activate Th2 and non-Th2 pathways as well. And this is the endotyping, based on the SARP data, okay? Early onset Th2, early onset Th2 with normal FEV1 or decreased FEV1, and late onset. I'm not going to go into much in details, as the next speakers are going to cover the topics. Mechanism of FDA-approved asthma biologics. We have the first one, 2003, anti-IgE, then anti-IL-5, so many came, then IL-4, IL-13. Now the TSLP is targeted, then TLR2, and then PGD2. There's so many about to come. So this is the horizon. Right now, the first one, anti-IgE, then IL-5, then IL-4, IL-13 specific, and then there is TSLP. We are quite excited. It's going to come, CRTH2, and then more back to the TLR, antagonists are also going to come in future. So with this, I thank you. In the interest of time, I haven't covered quite extensively in the last aspect, but my future speakers are going to cover. Thank you, Dr.
Thank you.